Welcome to this week's Silicon Slopes Town Hall. We have a very special guest. He's been on before, but we wanted to go deep with him today to discuss the states moving from red to orange, which means a moderate risk, I believe, but we'll talk to Dr. Good about what this means. We have Dr. Good. He's the CEO of University of Utah Health here to answer some of these questions. Dr. Good, the governor has made the call to begin reopening parts of our state. If you were a small business owner, as many people watching this are right now, what would you do? How would you protect yourself, your business, and your clients?
Thanks, Clint, and it's great to be here. As a state, we've been working together, government, business, health, and really a lot of the work former Governor Leavitt and his group helped us begin to organize different levels of activity as we deal with coronavirus. Other countries such as Singapore have done this red, orange, yellow, green because they've had to deal with previous viruses in a much more intense way than we've had to in the United States. And so probably about 3-4 weeks ago, many individuals began working on this red, orange, yellow, green. And I think to get to answer your question about, well, what should my business do? What does it mean for my business as we go to red to orange? Let's first paint the top layer here. You know, red is where we've been. It's stay at home, and only essential businesses are open, and pretty much no travel. On the other end is green, large group gatherings, travel as we used to know it, and all businesses open. So really the nuances, if you will, are what does orange mean and what does yellow mean? And kind of the overarching description of orange is that those who can work from home should continue to work from home. My floor here today is still empty because I'm in an administrative unit, and when I'm not in the hospital, my administrative team, they're going to keep working from home. Those businesses and those activities which cannot happen from home, those are the ones we want to re-engage. We need to practice, the physical distance, the hand washing, really try to remember the virus moves around in respiratory secretions. And so that's why we need to, as best we can, stay away from one another, wear masks, wash our hands, all the things we've been hearing. But in orange, it's those things, people that can continue to telework, should continue to telework, but it's those activities and those businesses that can't. I'll give you an example here from the university. I just told you my finance team, my HR team, they're doing just fine working from home. But our science, our bench lab scientists, they can't do their work from home. So we've spent a lot of the last few days really planning about how to resume important scientific activities that were not happening in a red condition, but will happen in an orange. We still limit groups in orange, and we still limit travel. In yellow, hopefully we're also trying to paint what yellow looks like, and that's where we start to move toward a little bit larger groups and kind of more encouraging than mandating some of these things. I want to say one more thing that's really important, and that is that those at high risk from having bad outcomes from COVID, particularly the elderly, particularly those with multiple medical conditions, those individuals should still stay in red right now. The virus still is in the community. It is still moving. And so high risk individuals should move into red. Lower risk, many of us, for things that can't be done remotely, should figure out ways to do those with the physical distancing. But so The answer to your question, Clint, is it depends on the exact nature of the business that you're talking about. If it's something that I have, see, 1, 2, 3 of my kids work in the tech industry, software. They're still working remotely. But things like bench lab research, there's probably other activities that just can't be done digitally. And those are the things that we want to start, those aspects of our economy we want to start seeing come back online.
Do you expect to see the number of diagnosed patients and the number of hospitalizations to increase, given that, more people will be out and about than have been previously?
I sure hope we do all the things we need to do as a community to not see that. But I do think we will. I think there'll be more human interactions. I've got a lot of folks really trying to focus on, again, those high risk individuals. It's not so, I mean, we want to slow down. Ideally, we'd like to get rid of this virus. But remember, it's the hospitalizations that we worry about, and preventing a situation from like what happened in other large cities from when there just weren't enough hospital beds, ICUs to care for everyone. So on the one hand, we're going to watch everything carefully. We probably will see increased cases, but hopefully, or not hopefully, we believe that if we all keep doing the right things we need to do under Orange, we'll be able to care for everybody in the hospital who needs a hospital care.
Dr. Good, is there a chance that we could go back to red at some point here? And what would trigger us going back?
Yeah, I reminded somebody the other day, the distance from orange to yellow is the same distance from orange back to red. You're right on, Clint. We really, we want to get particularly economically oriented activities that were not happening in red in the stay-at-home phase. But we also, if we go too far the other way, and as you just mentioned, if we see the case rising at an accelerated rate, and we anticipate that rate would overwhelm particularly the hospitals and the hospital beds, that would be the condition that I would be worried about, that we might need to go back to red. Remember, these things have like 2-week delays on them. The decisions we're making today will be seen a couple weeks from now. The things we're seeing today were based on things that happened a couple weeks ago. I get a couple of different reports each week on the so-called transmission rate. Each person who has COVID, on average, how many individuals are they spreading the virus to? And for about the 3rd week in a row, it's hovering in about the 1.2 range. You know, we got it down to 1. It's been hovering 1.1, 1.2. But I watched that real closely. And so while we're seeing more cases as far as case count, we're testing a lot more people. The positive, I just pulled it down, our positive rate is running right at 4.3%. So remember, it was about 5, now it's down to 4. That's much lower than the national average that's running around 17% positive. So there is about 1 in 20 or so, a little less than 1 in 20 now, folks in our community with coronavirus. And our mortality rate, you know, every lost life is very unfortunate, but we're running less than 1%. Today's number, we're at 0.9% mortality nationwide at 6 and worldwide at 7. So we're doing a lot of things right. And you asked me what would be some of the triggers that would cause us to have to go back to red. And that's if we really start to see the number of hospitalizations accelerate in a way that worries us, that we'd get to some of the conditions like some of the other big cities. And some that are still experiencing that.
Can I get your take on some of those numbers you just mentioned, particularly the fact that we have? Did you say it was around like a 4% positive rate versus around 17%
Yeah, the
nationwide?
numbers I'm showing for today were, and this is, the whole experience. We've tested just under 125,000 people in Utah, and we have the 5,300 cases. So that's about 4.3% positive, 4.3%. And the current national average is running 16.5%.
Why is that? Is that because we have more testing available and we've tested more people with minor symptoms, with no symptoms? Because I think I saw somewhere General Burton said we were second in the nation. I think it's vacillated between.
Yeah, it's like a lot of those rankings. It's tight at the top. Today we're number 5 in rankings, but just a few more tests, we'd be number 4. But we're right up there in some of the best tested states. I do think that's part of it, Clint. We've been able to test more people more quickly. So there's probably things we know and things we don't know. What do we know? We know we're testing among the best in the country, among the best in the world. Some argue maybe there's just, we tend to be a healthier population. We're also one of the healthier groups, states in the country. So maybe we pick up some underlying stuff there. We have a lower tobacco, cigarette smoking rate than others. So there's, like I said, there's probably things we know and that we don't know. We are also, just while we're talking about testing, today we began doing a field test where we just go out and try to test groups of people that represent the state of Utah, in terms of demographics and all that. And that's just getting started, but that'll tell us 2 things. We'll try to get a measurement on a number of asymptomatic people who are having the virus. And then we'll also be drawing the blood to do the antibody tests. So we'll start to try to understand, are there people who have had coronavirus, developed antibodies, and just, either had mild illness or maybe didn't even feel that they had illness as well. But so that's because of the testing capacities here in Utah, we're able to start doing that in addition to testing people who come to the hospital and are ill.
Dr. Good, can you talk a little bit more about your focus on at-risk individuals and especially their living environments as we start to go from, now that we're in this orange versus red, for these at-risk individuals and their living environments? Can you talk more about that?
Sure. And thank you, Clint. That's really the thing that I'm really encouraging us to focus on. I just called it up here. So the categories of individuals that are it's called higher risk for severe illness. So who are the people, if they get coronavirus, if they become infected with coronavirus, are at higher risk for having severe illness? Those over 65, those living in nursing home or long-term care facilities. The next group are medical conditions. As I told you before, the chronic lung disease, serious heart problems, immunocompromised, like if you're on certain cancer treatments, things like that, if you have an immune deficiency, severe obesity, diabetes, kidney and liver disease are the kind of the list. And the more of those conditions you have, if you get coronavirus, you don't have the same reserves as somebody who doesn't have any of those underlying illnesses. So then the next group are those that live in environments. It gets back to this population density. So shelters, group homes, other types of communal living. We also, often there are many generations of one family that will live together in a home or in a dwelling. And in those environments, you worry about, maybe a teenager or younger child who might get corona and not even know they have it, but come back to the house and share it with grandpa or grandma. So we're trying to work hard on focusing on areas where people cannot achieve the physical separation, in their home. I think I covered most of them. Let me check here real quick. Densely populated, multi-generational homes. We're also another group is individuals who cannot work from home, as we were talking about, and to maintain a livelihood, to maintain the family income, have to continue to go to work. And as a population, we're trying to make sure we really understand those individuals, where they're living. And this relates to some of your questions about are there things that employers can do to help, particularly in industries like mining and power and some of the industries where you have to be there and it has to be hands-on. So,
Dr. Good, what about our prison population?
yeah, it's prisons, detention centers. I'm not up to date on all the specifics about what's going on in our prisons, but that is the type of living environment where you have a lot of people
Right.
in close proximity. So as one of the things is we've moved from red to orange. The health department is really trying to make sure we continue to look at these high-risk populations, both at high risk for spreading the disease and then also at high risk of getting severe disease, which might cause the need for a hospitalization.
Right. We have a question from someone watching here, Dr. Good. They're wondering how much weight of the decision to move colors and open up has to do with strategic exposures and development of a herd immunity.
Yeah, great question. I'm not sure I like the term herd immunity, but it is what's used in the field. The notion is that as a community, as a new pathogen enters a community, and individuals begin to experience and recover from that pathogen, in many cases, certainly with many viruses, we develop antibodies in our bloodstream. And we are seeing, that's the so-called antibody test or serology. We now are able to measure for that. And we're just getting started in making those measurements in the community. I will tell you that we looked at our healthcare workers here at University of Utah Health, including those that are, or especially those that are in our emergency department and those that are on the wards that are taking care of the COVID patients. And so far, we're only seeing about 4% of our own healthcare workers having the antibodies. Part of that's good news. That means our personal protective equipment and the way we've worked to help protect them as they care for COVID patients, that's really the most important thing. But we've got to get out and doing the tests, but the early sampling is that, we're looking at low levels of antibodies in the community, which means we are far from so-called herd immunity. With other viruses, other similar viruses, you need to get up to 50, 60, 70% of the population before. What that means is the virus is looking for someone to infect, if you will. And if someone has antibodies, even though that person comes in contact, we haven't proven, but we believe that person would be unlikely to either get it or to get a severe case. there's a report out of Santa Clara, California, where they similarly found about 4%, 4 or 5% of citizens in the community with antibodies. About the highest I've seen so far was, I think it was 14% in New York City. So the concept of group immunity, having so many people that have some antibodies against it, is desirable, and we want to get there, but early indications are we're still a ways off from that.
Dr. Good, we're seeing the use of those home tests where you do the nasal swabs, particularly being made popular in large states like California. Are those tests where they're swabbing themselves at home? And I think they might be shipping it to, I'm not sure how it's working, but I'm sure you've seen like Los Angeles, for example, has gone to this because they're trying to get widespread testing on top of other things. Are those tests reliable?
The I'm trying as hard as everybody else to keep up with all of the new testing methodologies. We've seen the self kits that or the self where you do the nasal swab yourself. There was a early version of where you would spit into a container and they could do the test off of that. Now, the first ones that came out like that, there were eventually found to be some problems, but people keep working on that. And there's many of us that are hopeful that they'll keep working on some of the less invasive tests so that the specimen can be gathered. And, you think about all of the steps that saves. We don't have to have someone, obviously you can do it in your home. You don't have to travel. We don't have to have personal protective equipment on the healthcare worker. So we're watching all of that. I'm not familiar with all of them, and of course we want all of them to go through the necessary checks to make sure they're accurate. The one thing we don't want is somebody getting a negative test when they really have it. That false positive is the one we really worry about. If somebody gets the false positives are also something we want to avoid, but if you got a false positive, you would go and quarantine yourself. And so that if you think about the consequences of each, it's the false negative we worry about. But anyway, I don't know any of the specific ones that you're referring to, but I am confident that the pace of innovation that's going on in our country right now, among many of our companies, including many of the companies that belong to Silicon Slopes, the pace of innovation is just really inspiring. And so I'm confident sooner or later we'll get a less invasive test to detect this virus, and even hopefully the antibodies as well.
Right. I want to ask you about the antibody test in a second, but another question we've received is what can we learn from other countries like Sweden or South Korea about how the virus reacts to repeated and long exposure?
You mean how
Yeah, the question is, what can we learn from other countries like Sweden and South Korea about how the virus reacts to repeated and long exposure?
Well, I assume you mean how people react to being exposed to the virus multiple times, if I'm understanding the question right.
Yeah, this question was submitted by through the chat here. I assume that's probably what they mean.
Yeah. Well, so it comes back to the antibodies and the presumed immunity. Many coronaviruses and viruses like other viruses that cause flu-like illness, if you get the virus, you develop your antibodies to it, you either get partial or in some cases full immunity. And we have to prove all that, but most people believe we'll get at least partial, and if not, some pretty good. So that would mean if we were exposed to the virus a second time, we would either have, after you get the virus, you recover, a month or two later, you are again confronted with the virus, that you either would not get sick from the virus or you would have a much less severe episode. Again, all of that to be proven out, but certainly works that way with other viruses that cause flu-like illnesses. Now the viruses, we all know this story. Many of us, hopefully all of us, get our flu shots in the fall, and sometimes the virus will mutate or not show up exactly the virus that we thought was coming, that was going to predominate during that flu season. But even if we get the flu vaccine and still get the flu, we often tend to have a lot less severe case. And so that's what folks are hoping. I don't know, there are some reports out of South Korea, of people that they thought got infected a second time. There's only a few of them, and I've heard, both sides, oh, maybe the immunity isn't as good, or some say there do appear to be individuals that shed virus for a lot longer period of time than we originally thought. So those are some of the things I'm familiar with coming out of particularly South Korea.
Right. Dr. Good, I know the U has a number of clinical trials you're running on various drugs that could potentially, hopefully, help combat this thing. Can you give an update on those trials and what the trials are, like what the drugs are that the U is running trials on, and if there's been any update?
Yeah. There's 4 that I know of. We've been a national participant in the remdesivir trial. That's a trial of a drug that's typically given to the most severe patients who are really often, typically in the ICU. Their symptoms are so severe. Like many of us, we heard the national report of that. I'm not familiar with any. We try not, when we participate in a national study, we move our data forward to the national thing. And I think we've had just a few patients. Again, we've been very fortunate in Utah. I think I had a briefing last week. I can only speak for the University of Utah Health. We've had a total of 27 patients in our ICU. And I think it was, we've had all of the patients either are recovering, except for about, I think it was 6. So it's a smaller number. But anyway, we're participating in remdesivir. We also have a study going on in hospitalized patients for hydroxychloroquine. We also have a large hydroxychloroquine study going on in partnership with Intermountain Healthcare. I don't know how many we've enrolled so far, but we're working to try and enroll 2,000 patients in that outpatient study. That would be one of the larger outpatient studies in the country. And then the 4th area is, and I know Intermountain has been doing this as well, is the convalescent serum transfusions. Both institutions now, we've got enough patients that have recovered from their coronavirus. We're able to take their serum with those antibodies and give them as a transfusion into somebody who's really having severe symptoms. So those are the 4 that come to mind. Like many things, I'm probably forgetting 1 or 2, but those are the main ones that are up and running and enrolling patients.
On the 2 that have gotten the most media attention of what you just mentioned is remdesivir, and there have been reports of that may be seeing some success or maybe not. It might be too early to know. And then the hydroxychloroquine one, I believe the U is one of the first to start working on a hydroxychloroquine clinical trial. Is it too early to know on that trial with hydroxychloroquine, whether that's going to prove to be effective, or if the reports we're currently getting now is that it's probably not as effective as once thought?
The short answer is yes. It's too early to tell. For lack of a better word, these protocols. First of all, the reason that we well, there's a lot of reasons. We prefer to study this drug in a clinical trial. One of the reasons is we can follow the patients very closely and make sure they get check-ins and make sure they're not having side effects, and that we can carefully track how well they hopefully recover from their disease. The studies are governed by scientific review boards and so on. And, we're really, I don't know how else to say it, we don't peak. We let the study run its course, and then we examine the data. There are so-called break the glass if people are doing exceedingly poorly, or if people are doing exceedingly well. There are protocols for breaking the glass, and so-called, the old fire alarm analogy, and looking at the data. And so, best of my knowledge, none of those have been triggered. So the study's moving along, and I get periodic updates, just making sure the enrollment and all that's going well. And I just say, as soon as we know something, we'll be happy to share it with the
Yeah.
community.
Dr. Good, can you explain the antibody tests? I know this is something that ARUP has done a wonderful job on. We had Dr. Julio Delgado, who runs the lab for ARUP, on last week to talk about this. But can you explain, once this is up and running and once this is more widely available, these antibody tests, what it would mean to test positive or to test negative with an antibody test?
So the antibody test, and the one we're focused on, is IgG, immunoglobulin G. When your body is first attacked by the virus, there's actually an IgM, a very quick antibody that comes up and does the initial battle, if you will, while your body builds IgG. IgG is a much longer lasting antibody, many months. And so kind of, I guess, three things, Clint, to what does it mean if I've got a positive coronavirus antibody. One is, it means your body has confronted, and if you're well, it's warded off coronavirus. We still believe there are many people who have had coronavirus and their illness was so mild, they may not realize they had coronavirus. So one is, if you got an antibody test specific for coronavirus, you probably had the infection. The second thing is, and again, we've got to pay attention with making sure the immunity is as good as we think. But in theory, somebody who's, particularly if the immunity turns out to prevent you from getting a second infection, that person can be a little bit more comfortable. If they're making that really tough decision, do I go to work and keep income coming to my family, or do I worry about becoming infected with coronavirus? If I have antibodies, that's another piece, that's another data point that might make me a little bit more comfortable being out a little bit more in the community. And then finally, there is probably at some point, as we start to get large numbers in our community with the antibodies, there's probably a similar aspect for an employer to know that their workforce has already confronted the coronavirus. And again, we really believe or hope that the immunity bears out, so that individual would be less likely of getting it or getting a severe case. So to me, it's three. It helps show the group that's had it. It helps the individual who has the positive antibody make decisions about in their life. And I think it will also eventually help employers as they know how much of their workforce has confronted and beat the disease and how many have not.
Dr. Good, I know you're super busy. I have two more questions here for you. One, which I actually think is pretty interesting, is those who have been diagnosed with COVID-19, what treatments are currently being used on those patients?
Well, the because as we've talked before, other than those medications that we mentioned that are in clinical trials, we don't have a known drug or a known vaccine. Um, so the treatments that we're seeing are mainly what we call supportive. Um, you know the various medicines we take when we have the flu, the everything from the Tylenol to good chicken soup and all of that. As people, unfortunately, again, less than 9% of those that are getting coronavirus are needing to come to the hospital. So that's the vast majority of folks, just with the over-the-counter medicines and a little bit of rest, or resting and so on. As you get into the hospital, usually the first line treatment is oxygen. So this is a virus that wreaks havoc with our pulmonary system. And so we begin to put increasing amounts of oxygen to help the patient. We manage their fluids very carefully, their intravenous fluids. Many of them will become too sick to eat. And so we're making sure they stay hydrated, but it's a balancing act. That warfare that's going on in our lungs between the virus and our immune system, it the fluids tend to accumulate in the lungs. And so a variety of lung therapies are kind of the mainstay, but all of the things that go into taking good care of people in the hospital, making sure they keep motion so they don't get blood clots and things like that. The very sickest of the patients, and again, so fortunate that our mortality rate is low, but those that continue to deteriorate, often they'll have a breathing tube placed, and rather than just putting the extra oxygen around the face, we actually have to put it into the lungs through a mechanical ventilator. That's an uncomfortable, it's uncomfortable to have that, and probably some of your listeners have had that, or a family member has. So we tend to then add sedation, so that the patients, we try to get them to sleep a little bit rather than being aware and having this machine breathing for you. But most of the therapy, in addition to good around hospital care, good around ICU care, a lot of the focus is on the lungs and getting oxygen into the bloodstream.
Dr. Good, the final question comes from the chat as well, and I think it's interesting because I haven't heard an answer to this question so far, and that's around our children, Utah's children, and the fact that schools will remain closed. And this particular question is, when can we let them play with friends again?
The well, you really did save the hard one for the end. Again, I'm going to punt a little bit because we're trying to learn as fast as we can about this virus, and we do know that other flu viruses move around in the children, but influence them, affect them much less. And so I'd probably have to go talk with some of my pediatric experts and help understand where we're at with this particular virus. But the speed at which things are being studied, analyzed, and reported. I was following over the weekend. Remember the USS Roosevelt, the aircraft carrier that I think nearly almost 1,000 of the women and men sailors out of 4,000 became infected with the virus.
Right.
Now, as they're moving toward the end of that infection and recovery, if I understand things right, 4 or 5 out of 1,000 ended up in the hospital, and only one death. And people are trying to understand. I mean, we thought we were doing well in Utah. That's an even more impressive, again, no illness, no loss of life is good, but one death and 4 or 5 hospitalizations out of 1,000. And so people are looking at, one of the things the military does is you get your MMR, your mumps, measles, rubella vaccine, regardless of previous status. So there's a whole line of investigation going on right now about cross-reactivity from some of these other vaccines. And when you mentioned the children, that made me think of that, because it's the children that tend to have that vaccine more recently than certainly the vaccine wasn't even around for a lot of us. So we'll keep that. I understand you ask a very practical question. When do I get out of this home teaching assignment that I didn't sign up for as a parent? I get that. I think my daughter-in-law is about ready she's got 3 small children, so I know exactly what you're talking about. But I'll ask some of my pediatrician friends, and maybe at a future podcast here with you, we can provide a little bit more informative answer to that really, really important question.
Perfect. Thank you, Dr. Good. And I just want to thank you and your team and everyone at the University of Utah Health who is working so diligently and has responded in such a remarkable way to COVID-19, in particular the medical professionals who were on the front lines fighting this and serving, those who have been affected by COVID-19 directly. Thank you for everything you're doing. Silicon Slopes is so proud to be partnered with University of Utah Health. And, before this, we were proud of our partnership with you, Dr. Good. And now we couldn't be more proud to be associated with you and your team. So thank you for everything you're doing. Thank you to all the medical professionals on your staff. And we'll keep following your lead, sir. Thank you.
Well, we're in this together, and we're winning because we're hanging together. So we're gonna keep pushing. Thank you, and thanks all your great organization does, and particularly for the companies and the people in the companies with which Silicon Slopes represent.
Thank you, and thank you. You as well. That's this week's town hall. We'll have another one Monday at 4 p.m. Make sure you tune in. Thanks so much.